first little clinic, and I picked Iris because she'd done this with me, but she's also a pediatrician, which is perfect for cyclists. But to her horror, who signed up to come for this but a real neurologist who just started.
So we're talking about concussions, head injuries. And there are three things that I want to make sure that we talk about. How to identify what's a concussion in the first place, management of concussions, what you do because you might be the only person next to that person having a concussion, and prevention of cumulative and chronic brain injury. And so, should not make this something that will go on throughout your life. So first, recognize a concussion. More than 80% of individuals with a past concussion didn't even know they had one. And because of the ramifications for later, this is kind of important to figure out if you've had a concussion. Alright, so things that you may notice about somebody who's had a concussion. They might have a vacant stare, kind of just staring off into space. They could be slower to answer your questions or follow what you're telling them to do. They can be easily distracted, unable to follow through with kind of the normal things you're asking them to do. And I was joking with my kids, it kind of sounds like my kids when they haven't had a head injury. But in general, just remember they're just staring up into space, not following what you're saying. Other stuff you might notice, they're a little bit disoriented. They're kind of walking in a funny way, walking the wrong direction, unaware of the time, the place, the date. They might have slurred or incoherent speech. That's something to pay attention to. Observable incoordination. Again, it's not just walking the wrong way, just not really walking all that well. Other stuff you might notice, memory deficits. So it's good, like if they're asking you the same question over and over again. Or, one of the things we do, I know in my, education neurology, which I know I finished
don't feel the pressure.
We talk about memorizing three things. So it's good if you kind of say to them, okay, I want you to remember these three things. And a spoon, a book, a car, and then as you circle back and talk to them a little bit later and say, what were those three things I just asked you? And so, these are, three unconnected things. Any period of loss of consciousness, that's also kind of going to tell you whether or not you've had a concussion. So there's something called the Glasgow Coma Scale, and it's something that is a scoring system put together, I think, by a few neurosurgeons in Glasgow, Scotland, years ago, 1974 actually. And it was used to describe a level of consciousness in a person following a traumatic brain injury, as a way of kind of scoring what's happening. It's helped to gauge how severe it is. It's simple, it's reliable, it correlates with outcomes, and it's great for kind of recording what happened right at the time, like your score right at the time, and then your score a little bit later so you can follow that. And so, anyone, trained staff at the site of an injury in his ER and ICU, Shay actually was one of the first people, I think, who was assessing because of fallen, and just kind of going through some of the things to pay attention to. So it's not like I'm asking you to memorize the Glasgow Coma score, but I want you to have an idea of what we're talking about, because also first responders are going to want to kind of go through this. Eye-opening, verbal response, and motor response, and that's what we're looking for. When it comes to eye-opening, the score is anywhere from 1 to 3. You can't get a 0, so the most you can get is 1, so 1 to 3. When it's verbal response, it's scoring 1 to 5. The motor response is 1 to 6. So just to give you a little overview so you've heard it, eye-opening, if they spontaneously open their eyes, that's a 4. If it's to voice, it's a 3. If it's to pain, it's a 2. If it's not, they're not opening their eyes at all, that's a 9. That's a 1. Verbal response. Verbal response, okay, normal conversation, you got a 5. If you're a little disoriented with your conversation, you lose a point, you're a 4. If you have words but they're not really making sense, that's a 3. If there are no words, only grunts and sounds, that's a 2. And then if there's no verbal response at all, that's a 1. Motor response, same kind of thing. Normal is a 6. Localized to pain, like, yep, I feel that, that's a 5. Withdrawals to pain, that's a 4. And then there's decorticate posturing, where you're in a certain position like this for a 3, and then arch back and neck back if you have just cerebral, that's a 2, and then no motor response at all, that's a 1. So pretty quickly you can kind of see with scoring, if you've had a severe injury, you're going to be somewhere between a 3 to an 8. If you've had moderate brain injury, that's 9 to 12, and mild is 13 to 15. So mild injuries can result in temporary or permanent neurologic symptoms. So it's good to keep that in mind, even the mild ones. Neuroimaging tests such as CT scan or MRI may not show any evidence of what's going on. Moderate and severe brain injuries often result in long-term impairments in cognition, like your thinking, physical skills, and or emotional or behavioral functioning. So that's at the moderate to severe. So a head CT is recommended some of the time, but not always. So again, I'm not asking you guys to memorize any of this stuff. I know I'm not talking to you who are going to necessarily be ordering an MRI or a CT, but it's good to know. So if your Glasgow Coma score is less than 15, just less than a perfect, 2 hours after the injury, that might be a reason. Suspected skull fracture. Any signs of a basilar skull fracture. That's basically, if you have an injury here, you can get the blood that's right here called fracture. Or if it's accumulating back here, it's called battle sign. So you see first responders trying to check from back here. Looking in the eardrum, there can be blood pooling behind the eardrum. There also can be CSF. So CSF is your cerebral spinal fluid. When you get a spinal tap, that fluid that's coming out from your back is also bathing the brain. That can be leaking out of your brain through the nose or through the ears. So those are all things to look for. Vomiting 2 or more times, more than 2 hours. Vomiting 2 or more times enough for a CT scan. 65 years of age or older. So it's good to know that there's actually an age where if you've had a brain injury, 65 and older is enough to say we should get a CT scan. Amnesia before the impact of 30 or more minutes. And then anything that looks like a dangerous injury, like a motor vehicle accident, you might get a head CT because of that. And then there are other, so one other thing I just want to remember to mention, the presence of like a blood thinner on board. So if somebody's had a head injury and they're on a baby aspirin, that's enough to say we should get a head CT because that's enough to say your risk of actually having a more severe brain injury is there. Sometimes people get admitted to the hospital, they don't automatically need a CT scan, but they need to have someone who's kind of paying attention to the evolution of symptoms. So if your score is less than 15, if you have an abnormal CT scan, if you have seizures, abnormal breathing problems, or you're on an anticoagulant, like I was saying. But one key thing I want you to know is that one reason for admission to the hospital is if there's no one available to be monitoring that person in their progression of symptoms at home. So if you have somebody who's fallen who is living by themselves, that might be enough of a reason to be admitted to the hospital because this might evolve over hours. People with uncomplicated concussions should have a period of physical and cognitive rest for at least 24 hours or at least until the resolution of symptoms. So this is hard. I know as cyclists we're all used to kind of sucking it up and getting back on the bike and moving on, but don't do that when it comes to your head. If you have a headache, that's a reason to not get back on your bike. So that's something to pay attention to. And I would think of it like if you broke your arm and you kept using it, it's going to heal, but it might heal crooked, right? So your brain is going to heal, but it might heal crooked. So just remember that. There's a lot that can go wrong when you kind of keep pushing when you're not healed yet. So athletes should not return to play while symptomatic. So there are a variety of short and long-term kind of consequences that can have important complications. Again, I just want you to at least have heard of this. The one that really worries us all the most is second impact syndrome. It's rare, but it's fatal. It happens when there's brain swelling throughout the brain, not just in one area, and it's after a second concussion while an athlete is still symptomatic from an earlier concussion. So this is one of the big reasons to not get back on your bike when you have had a concussion, and now you all can recognize concussions, right? So you had a concussion, you get back on, and you fall again, that's a second injury while you still, and you're more likely to actually get another concussion. And so second impact syndrome actually kills. We don't understand why. It's thought to be messed up cerebral autoregulation with increased intracranial pressure. What does that even mean? It's like your anti-lock brakes just kind of freezing up. Something is just not working to get you to stop, the swelling that's happening. So it's a lot of swelling in a tight area. There's also post-concussion syndrome, where it's headaches and dizziness, neuropsychiatric symptoms. So what does this even mean? Neuropsychiatric symptoms are basically mental problems attributable to the nervous system, like depression, cognitive impairment. It develops within the first few days after a head injury, and it generally resolves within a few weeks or up to a few months. So this is, so I had to kind of look into whether an adult medicine is all different, because I'm doing, my practice is all pediatrics. But looking at the adults or the pediatrics, it's like, you can have long-term learning disabilities, and you're going to be a little bit more likely for these neuropsychiatric things that we're talking about. In the adults, it's not like the learning disabilities are the issue, but still the neurobehavioral problems I mentioned. Miscellaneous other things, post-traumatic headaches that keep going on for longer than the months, post-traumatic epilepsy, post-traumatic vertigo, other cranial nerve injuries like smell, taste, vision, those can actually get repeated from a concussion, and then chronic traumatic encephalopathy, and that comes from all the studies from the NFL. I don't know if you guys have seen the movie Concussion. If you haven't seen the movie Concussion, I really think you should. It's worth seeing. Return to play guidelines. So, and this is from adult stuff. I try to stay away from the pediatric stuff as I'm talking to you guys. Removal from play, if there's been a concussion, is important. Fear evaluation, if there's loss of consciousness at all. If a concussion has happened, it should be removed from play and practice until the symptoms are resolved off of medication. Not resolved because I took most of it. Resolved off of medication, then you can get back to what you're doing. More conservative recommendations are for the children and adolescents. If there are multiple concussions, a more detailed evaluation is needed for their neurobehavioral symptoms. So just long term, it's good to kind of keep that in mind. So, helmets. I have no other way of preventing. I'm not going to tell you to stay home and watch TV and not go out. You're going to go out, but at least put a helmet on, and then pay attention to all this stuff. And then I won't review all of this because Brian's just going to heckle me to death.
I'm heckling, I'm ready.
But get the right fit, and you can get this from anywhere on the internet on how to make sure your helmet's actually fitting correctly. Questions?
Yes. Did you say helmets? You did. Well, so the interesting thing is, if helmets were like a drug and they were supposed to prevent injury, the FDA would not give approval because they don't. Now, listen, hear me out. There's a few interesting factors. One is we behave differently with a helmet on. We take more risks. So that's us. More terrifyingly is there's a study out of Bristol, I think, where this guy did his PhD on how close a car will pass you, whether you're wearing a helmet or not. And it's 8 centimeters closer when you have a helmet on. So your behavior changes, and the people around you, their behavior changes into more risky stuff. But the other thing is, and we all know this, is a helmet, your TV came in more packing than a helmet. That thing is feather light, and if you know the test, they drop it 1 meter with a little ball in it. And if it doesn't completely disintegrate, it passes. Now, when you're in the real world, there's a reason you've got to see the test. Is this your field?
I've been listening about that, yeah.
Oh, okay. So I believe the healthiest perspective on this is to definitely wear a helmet. But don't think it's going to make you safer at all. In fact, think it's probably going to make you more prone to injury, because I think that would be the best.
I disagree.
You disagree?
So that's why you wear one?
Huh?
That's why you wear one?
That's what, I wear one thinking that it's not going to protect. I wear one thinking it's going to make me riskier, people around me riskier, and it's going to prevent me. And hopefully that changes the way I ride.
Yep. Guys, behavior related to helmets is different than your head contacting the ground without a helmet. It's completely different. There's behavioral issues, and there is the trauma that happens when your head contacts asphalt, and I've seen it without a helmet. I wasn't the one. It is horribly more traumatic than what happened to one of our riders on the tour. And yep, you could see where the helmet was torn up, and I'm like, oh, that would have been so much more terrible without a helmet. The effect of your head hitting the ground The concussion is probably the same in both cases, except the additional trauma that's incurred with your skull being cracked open and abrasions to the head, hair removal for hair that can't be removed. But behavior, I've seen the study. I think behaviorally, yes, there are behavioral issues with helmets, but
So I'll just tell you, the focus of what I was talking about was not so much the bleeding within the brain, the really bad headaches, but it was more on the concussions that can actually have long-term issues also, and what we can do to modify the long-term. So helmets is not exactly how I should have ended this talk. It's more, I want you to kind of pay attention to the symptoms and have the people around you, get a physician to check you out, and actually know, I don't want to be having issues related to that fall forever or for any long time.
And by the way, we're going to be doing this talk again because this was really good. We're going to do it again and again. It's important. One of the things that I want to add to this talk is, as men, it's often like, hey, Curtis, I know you shoot your head against the ground. Just get up and let's go. Come on, let's keep riding. You know, it's a thing we do. And on our ride, and Iris was there where we had a rider go down, and she's like, no, he's not gonna ride. Somebody go get a car, come back. I'm like, oh, come on. And that was an eye-opener for me to say, look, and you were right, by the way.
Because he had
And he did die. By the way, Robert did die. So you called it.
Can somebody take a picture? Yes.
You were
No.
It's because I know. No. So this somebody ever hit their head with a helmet.
I'm trying to
Did
make
not
this
look
more
at all
interesting.
like they had. Then there was bleeding in the brain. It didn't look like that. Now we're at the next level. This isn't even talking about whether he impacted the head. It was whether that headache was just going to go on and on and on. We were about to do a climb, and he was going to hop right back on the bus. And so it's like, yeah.
As men, we would have taken him up that climb. Last time we did, come on, look, we'll get there, we'll figure it out. You know, there was an external hemorrhage, so it's fine, stop bleeding.
C'est bon, stop bleeding.
Let's go.
Now there's more into your head than
Yeah. No, and even with us, I'm like, yeah, so he's a little slow. Come on, he's fine. He wasn't as responsive. But we're like idiot